Since the advent of cardiac surgery 60 years ago, intraoperative myocardial protection or cardioplegia respectively has been an essential part of open heart procedures. Experimental and clinical research on this particular field is still continuing because an optimal or ideal cardioplegic solution has not been established. In the past, surgeons focused, among other criteria, on intra-ischemic myocardial energy turnover or morphology, while today safety and convenience are the main parameters for evaluation of any cardioplegic method. Regarding surgeons' convenience, it is obvious that cardioplegic reperfusions or administration of maintenance solutions are the most inconvenient and time-consuming procedures. The following remarks focus on a method to avoid such cardioplegic reperfusions without compromising patients' safety. The answer to this progress is called CUSTODIOL. CUSTODIOL is a low sodium and low calcium cardioplegic solution and the only highly buffered compound available worldwide. Significantly, the histidine buffer represents the primary osmotic ingredient of the solution. In addition to its buffering capacity, histidine is one of the most effective scavengers of free radicals known, with its mode of action comparable to mannitol. Due to its highly concentrated buffering capacity, this solution requires only a singular administration to initiate cardioplegic arrest. What are the indications to use CUSTODIOL? At first, pediatric cardiac surgery. Also valvular surgery, followed by aortic surgery, minimally invasive surgery, redo surgery, heart transplantation. Finally, it can also be used in coronary artery surgery. In accordance with Dr. Cooley's recommendation, administration should be safe and simple, routinely using a 3/16 perfusion line and a 9 French aortic cannula. For intraoperative cardioplegia and transplantation, antegrade cardioplegic perfusion is preferred with necessarily a high-volume perfusion. Furthermore, in this situation, the extended perfusion time must be considered as the total extracellular myocardial space requires adequate equilibration. CUSTODIOL can be used at any patient age. However, in pediatric cases, special considerations apply. The perfusion volume must be adjusted for the infant's age, and perfusion time is shorter than in adults. Cardioplegic reperfusions appear to be harmful in neonates, as the listed references clearly demonstrate. How do we administer CUSTODIOL? After aortic cross-clamp, it is first necessary to empty the aortic root and the left ventricle. Then the cardioplegic perfusion is started. The solution can be administered either by roller pumps or by gravity. Electrically induced ventricular fibrillation should be avoided before cardioplegic perfusion starts, since the coordinated ventricular contractions during the initial phase of cardioplegic perfusion result in optimal equilibration. The decrease in the arterial-coronary venous PO2 difference is not affected by the mode of perfusion. The crucial reduction in the decline of the difference of arterial coronary venous oxygen partial pressure reflects reduced myocardial energy consumption, which, in turn, correlates with a corresponding increase in myocardial cell energy content. The solution's temperature should be kept between 6 and 10 degrees centigrade. Any unused portion from the initial perfusion should not be stored in a refrigerator, as rewarming will decrease the solution's pH, adding to the acidotic shift in ischemic myocardium. As already mentioned, cardioplegic reperfusions are not usually necessary. If, for some reason, cardioplegic reperfusion is necessary, perfusion time should be limited to 1 to 2 minutes, equivalent to 200 to 400 ml. Time lapse is the primary drawback of any replegia. It is evident that replegia is well known to be harmful to the neonatal heart. In case of initial retrograde administration and of retrograde replegia, consider the physiological fact that only 70% of the coronary venous blood drains into the coronary sinus. Consequently, right heart failure constitutes the main risk of retrograde administration. One additional concern relates to blood pH after systemic custodiol administration. The pH of this buffer-containing solution is temperature-dependent. At 34 degrees centigrade, the solution's pH is 6.9. We can predict the blood pH following systemic custodiol administration and thereby calculate the pH shift towards acidosis that is solely attributable to physicochemical effects. How to manage custodiol perfusion in patients with severe aortic insufficiency? Try to perfuse antegradely first. If the heart does not stop within 3 minutes, open the aortic root and continue with isolated left coronary perfusion. In most cases, the heart will stop with this approach. If it does not, interrupt the left-sided perfusion and perfuse only the right coronary artery for 1 to 2 minutes, and then continue the left-sided perfusion. If retrograde perfusion is preferred, perfusion pressure should be only 20 to 30 millimeters of mercury. Systemic administration leads to hemodilution, which can be prevented by a hemofilter. It has been suggested that systemic custodiol administration leads to neurological seizures in neonates due to systemic hyponatremia. However, this is not the case. Studies from Norway and Italy demonstrated that an apparent hyponatremia, based solely on measured laboratory serum concentrations, is not causally related to seizure activity in this situation because it is isotonic. To prevent such hyponatremia, administration of 200 to 300 millimole sodium to the body's circulation is recommended. Obviously, sodium chloride must not be added directly to the cardioplegic solution because this would seriously interfere with its effectiveness. Our recent retrospective as well as prospective studies on systemic sodium content and osmolality clearly support the validity of our aforementioned protocol in preventing systemic hyponatremia. If intra-procedural ventricular activities appear on the screen, look for causative factors. Among the factors listed, a relative increase of venous pressure is the most likely cause, since the plegically arrested heart muscle is maximally relaxed. Once all aforementioned factors have been considered, accept up to 5 minutes, because these activities subside spontaneously without replegia and do not recur. Optimal effectiveness of custodial cardioplegia can only be achieved if both cardioplegic perfusion is conducted and myocardial equilibration is effected in accordance with the above guidelines. Safe cardiac arrest for 3 hours is guaranteed in open heart surgery and for 5 hours in heart transplantation.